Now let's study pneumothorax. Pneumothorax means accumulation of air in the pleural space. As we know, there are two pleural cavity, visceral and the parietal pleura. Visceral pleura is attached to the lung and parietal pleura is attached to the chest wall. And pleural cavity is lined by mesothelial cells. As we can see in this picture, we have the two pleural layers. Visceral pleura is connected to lung and the parietal pleura is attached to the chest wall. There are two types of pneumothorax, spontaneous pneumothorax and the traumatic pneumothorax. Both spontaneous and traumatic pneumothorax leads to tension pneumothorax. Now let's see primary spontaneous pneumothorax. This occurs due to a rupture of the apical subpleural blebs or cyst. If we consider this as the lung, and we have pleural layers, visceral and the parietal pleural layers, and sometimes there will be blood formation or small cavity formation on the lungs, and when this blebs rupture, air moves from lungs to the pleural cavity. When this happens, there will be change in the negative pressure. As we know, within the pleural space we have the negative pressure which keeps the lung open, but when air moves from lung to the pleural cavity, there will be changing from the negative pressure to the positive pressure in the pleural space, and this leads to loss of lung volume, and that leads to increase in the pleural space pressure, and this leads to collapsing of the lung. Eventually this leads to collapsing of the lung, and this is associated with tall, thin, young males because they will have more negative pleural pressure, and this is also associated with tobacco smoking. Secondary spontaneous pneumothorax. This is seen in diseased lung like bullae in the emphysema that ruptures, or also seen in connective airway diseases like Marfan syndrome or Ehlers-Danlos syndrome and infectious conditions, and it is also seen in mechanical ventilation with use of high pressure that leads to rupture of the or air in the pleural cavity. And the pathophysiology is there will be spontaneous rupture of the apical subpleural cyst, bullae or the bleb. In secondary spontaneous pneumothorax, there will be bullae that rupture, and due to rupture of this bullae, if we consider this as lung, these are the pleural layers, and the bullae will be larger than the blebs, and there will be rupture of this bullae and air entering from the lungs to the pleural cavity. Hence, changing of the negative pressure to the positive pressure within the pleural space. Hence, this causes loss of lung volume, and increase in the pleural space pressure leads to collapsing of the lung. Eventually, the lung will be collapsed. In spontaneous pneumothorax, trachea will be deviated to the same side. Let's see some figures. As we can see here, this is the bullae and this is the blebs. Bullae are larger than the blebs. Bullae are commonly found in emphysema patients, and blebs are small cysts which are formed in random people like tall, thin males, and due to a connective airway disease patients like Marfan and Ehlers-Danlos syndrome patients. And these bullae membrane are thin, and they can take up much air during inspiration, but since this is one way connection, the air that enter during inspiration will not go out. This bullae will eventually get bigger and bigger, and after some time they will rupture, and When these rupture, the air from the lung will go into the pleural space. As we can see here, this is the gross lung. Here we can see the bullae in emphysema patient. And here we can see the bullae that leads to air entering into the pleural cavity. And this is the collapsed lung due to spontaneous pneumothorax, that is air entering into the pleural cavity that causes the collapsing of the lung. And here we can see the bullae that caused the collapsing of the lung. Here we see the black space, this is the air. Next, let's see traumatic pneumothorax. Here this can be due to blunt injury like rib fracture, or it can be due to penetrating injury like gunshot wound, or it can be iatrogenic, that is during central line catheter placement and lung biopsy, barotrauma due to mechanical ventilation. Let's see what happens in blunt and penetrating trauma. In blunt trauma, as we can see here, the fractured rib will disrupt the lung parenchyma, and this causes the loss of lung volume, and there will be increase in the pleural cavity pressure from negative to positive. Normally pleural cavity pressure is -5, and this -5 will be shifted and there will be increase in the pleural cavity pressure. Upon inspiration, intrapleural pressure on the collapsed lung will be increased, and this causes the deviation of the trachea away from the affected lung, because pleural pressure will be so much increased that it will be pushing the trachea away from the affected lung. And in penetrating injury, the mechanism is same, but here there will be penetration of something like gunshot wound, and this increases the pleural cavity pressure and shifting of the pleural pressure from negative to positive, and lung will also collapse, and this also deviates the trachea to the other side because the pleural pressure will be so much decreased, and this causes the deviation of the trachea to the other side. As we can see in this figure, here we can see the rib fractures. This leads to blunt trauma, and this leads to traumatic pneumothorax. See tension pneumothorax. Tension pneumothorax can be caused by spontaneous or traumatic pneumothorax. Here air can enter the pleural space but cannot exit, and due to increased air trapping, this leads to tension pneumothorax. And here trachea will deviate away from the affected lung. This can be remembered by keep the tension away, that is in tension pneumothorax, trachea deviates away from the affected lung, and this leads to increase in the intrathoracic pressure, and there will be mediastinal displacement. When there is mediastinal displacement, this leads to kinking of the inferior vena cava. When there is decreased size of the inferior vena cava, this leads to decrease in the venous return to the heart, and this decreases the cardiac output and eventually leads to obstructive shock, that is hypotension and the tachycardia. There will also be jugular venous distension. These are the main findings to be checked while monitoring the tension pneumothorax, and there should be need of immediate needle decompression and chest tube placement, and there will be no time for doing the chest x-ray for the tension pneumothorax patient. Hence we should find out the hypotension, tachycardia and jugular venous distension. These point out to the tension pneumothorax. And the clinical presentation of pneumothorax patient is dyspnea, that is shortness of breath, and uneven chest expansion. One chest will be expanded normally and the other will be expanded unevenly, and chest pain will also be there, especially pleuritic chest pain, and decreased tectus fremitus. And normally hyperresonance will be heard and diminished breath sounds can be seen. As in pneumothorax, this is only on the affected side. If this happens bilaterally, that is cardiac tamponade. That is chest pain, tactile fremitus, hyperresonance, diminished breath sounds on one side. This leads to, or this points out to the diagnosis of pneumothorax. Or else if bilaterally, that means that is cardiac tamponade.